Okay, so I'm going to go over a concept that seems pretty straightforward, but I've kind of developed a method that I think helps us to avoid doing unnecessary root canals, which is really what we're trying to do. Um, so I've put together a couple of concepts here. So today we're going to go over basically diagnosing root canals and exactly the verbiage that we use at every type of um, toothache. And I titled this Endodontic Diagnosis for Your Mother. Why? Um, the first concept we really should think about is this, that we need to treat every single patient like we would treat our own mother. And when you have that in your head, and especially with every type of clinical scenario, you start to change your mentality on, hey, what exactly is going on here, versus what would I do if this were my own mother? Okay, so the absolute most important thing is to do this, do all of these steps as if you would do it on your own mother. Okay. Part of that is you should be super sad when you have to do a root canal. I think as new dentists, we get super excited to be able to pick up the drill and do a procedure. You should always be super sad. I mean, I've always felt that it's the weirdest concept in the world that taking a drill to someone's face is actually helping them. Absolutely not. We only do anything if it's our absolutely last result. There's nothing else that we can do. So we need to be super sad when we're doing root canals, but we should be super happy that we are able to do a root canal for the patient. Again, that's why we encourage general practitioners to do all molar endo. Why? Because patients don't have another option. They are in extreme amount of pain, or they have an abscess, or both, and they literally have the choice of you with your dental degree who's gone through endodontic classes and have experience with endodontics, or uh, because of the financial concerns, or maybe they're seeing us on a Saturday, they don't have access to an endodontist. Okay, and so they can either get a root canal done, or get a root canal started by us, general practitioners, or they can go home in their garage and have their friend Billy Bob grab some of the pliers, some rusty, greasy tire pliers out of their toolbox and have them try to take the tooth out. So you need to be in a situation where you are comfortable and confident in doing root canals. Okay. Another concept that we need to know is that every root canal can fail. Okay. Um, every root canal over time has the ability to fail. One of the reasons that I think that this happens is um, there was a source cause of this patient needing a root canal. Usually it is a combination of the patient's oral hygiene plus their dental anatomy that causes bacteria to accumulate around that particular tooth, that cause the caries, that cause the invasion of bacteria into that canal. And uh, in reality, when we go and do the root canal and the crown, have we really changed either of those two factors? Probably not. Very few patients um, start to have better oral hygiene just because we did a root canal. And we definitely didn't change their anatomy. So that root canal has a higher probability of having recurrent decay underneath that crown. And as we all know, nothing in dentistry is as good as what Mother Nature gave us. So there is a probability of that root canal failing. So if that's the case, we should try to avoid doing root canals unless we're absolutely sure that it needs a root canal. Okay. Another concept here. If if you are out there looking for root canals, okay, um, and especially on patients that tooth doesn't hurt, okay, so there's basically three ways that you could be out there looking for root canals. Um, one would be is um, and I've heard this from younger doctors. Why don't we take a PA on every single tooth in the mouth? Because the PA is going to have higher resolution than the pano, and it'll help us find pathology. Okay. Um, I don't super agree with that. I think that there could be false positives, especially around the sinus areas and things like that. I was at a CE course in Buffalo, New York during dental school, and the presenter there was saying that pulp stones could only happen when there was an invasion of bacteria. So if there's a pulp stone, you need to do a root canal. Again, that's totally false. Um, I've seen pulp stones on teeth that have never had a single cavity on it. And so to me, that's someone who's looking for root canals. Okay. We need to be not looking for root canals. We need to be sad that we have to do a root canal, not happy that we have to do a root canal. Okay. So taking PAs of every tooth, trying to find pathology. Okay. One extreme would be I've seen an endodontist who takes a CBCT so that they can find pathology. Okay. Another one would be is to pulp test or endo ice test every single tooth in the mouth, trying to find root canals. Okay. The bigger concept here is this: if it does not hurt on the patient, and you do a root canal, and then it eventually fails, the patient is going to blame you. Okay. Um, so don't go trying to find root canals. Okay. The only reason you should do a root canal is because the patient is in pain and wants the root canal. Okay. Or if the patient can see the abscess clinically or on the x-ray. Those are the only reasons that you should do the root canal. Okay. Another concept that seems to be lost on newer doctors is the best diagnostic tool is the patient's finger pointing to the tooth that hurts. Okay. So I see a lot of doctors just rushing in and doing pulp vitality tests or things like that. Why don't you just tell the patient to point inside of their mouth to the tooth that they think it is? Okay. Because the concept is this. Okay. If the patient says, listen, I've got pain on the lower right, and um, you go and do a bunch of your tests and it ends up being the wrong tooth, you're kind of to blame. Okay. Versus if you tell the patient, hey, can you point to the tooth that you think it is? And let's say that they point to tooth number 30 and tooth number 30 and 31, you were kind of thinking needed it. Well, if you end up doing the root canal on tooth number 30 and it didn't resolve everything, they probably needed a root canal on both 31 and 30. But is anyone going to blame you, especially the patient, that you did a root canal on the tooth that they pointed that they needed a root canal on? Absolutely not. Okay. So the best diagnostic tool is the patient's finger pointing to the tooth that hurts. Okay. Another concept is this. Um, you know, Doctors want to have an absolute diagnosis of what's going on. Okay. And a lot of times patients will say, well, it's one of these two teeth. Okay. And so doctors get out all of their gizmos just to give them the final diagnosis that day, okay? Which is absolutely wrong. Okay, if you can't find which tooth it is, imagine this. Okay, patient has 10 out of 10 pain on the lower right, and it's 10 out of 10 on tooth number 30 and 8 out of 10 on tooth number 31, because it hurts so much, they can't really tell the difference between 30 and 31. So when you go and tap on it, both of them hurt. Okay, so then the doctor decides, oh, I'm going to get out some gizmos and see if I can identify if it's tooth number 30 or 31. No, you don't have to do that. What you and the other concept that I'll tell you about is using endo ice on a tooth that hurts is just going to make the patient mad. So instead, try doing things that are less invasive. Maybe blowing some air on the tooth, okay? Or get the patient on an antibiotic for a couple of days. And then instead of the pain levels being 8 and 10, which are very hard to distinguish, okay, they'll now be a 4 and a 2. And it's super simple for someone to say, yep, I figured out, and I've spent a couple of days thinking about it. And yes, tooth number 30 hurts twice as much now as tooth number 31. Whereas before, it only hurt 20% more than tooth number 31. Okay. Final concept here is, if you love endo ice so much, okay, so doctors love to get out endo ice because they're going to test to make sure that they know, and they've got this little gizmo to tell the patients, listen, I'm so smart, I can tell you which tooth is the one that needs the root canal. Okay, if you really love endo ice so much, then I would dare you to have you bring your own mother in, okay, and I get to endo test every single one of her teeth, and if there is a tooth that gives no response, I get to do a root canal on her tooth, on that tooth, okay? Would you allow that to happen with your own mother? No, you wouldn't. So why are you doing that on your patients? Okay. As a general practitioner, you do not need an absolute diagnosis today. Now, do endodontists need endo ice? Absolutely, because they need to be sure that day what they're doing. Okay. So I just Googled endo ice test. Okay. And I came up with this article. Okay. From School of Dentistry, University of Southern California, okay, and they're talking about endo ice tests, okay. Look at this, look at this statement here, okay. Moreover, 1 out of 10 teeth tested with cold or EPT will be incorrectly diagnosed, okay. I think that's the concept that you kind of get when you think about bringing your mother in to have her tooth tested with endo ice. You are not absolutely in love with that idea because you know that there's going to be a tooth or two in her head. She's got 28 teeth in her head. I bet you there's 2 or 3 that will be not will test as non-vital. Okay, so the use of endo ice is super contraindicated in the general practice. Okay. Um, the other thing that I'm going to tell you about endo ice is it hurts the patient. Do you want to come in and a patient is in pain, and instead of you trying to use, something as easy as air or having them go on amoxicillin for a couple of days, you're going to put a cold object on on top of um, on top of that tooth. It's very similar to, a patient has 2 scratches on their arm. And you're like, okay, well, let me figure out which one is hurting worse. I'm going to put salt on wound number 1, and then I'm going to put salt on wound number 2. It's the dumbest idea in the world. Don't use endo ice. It's only going to make your patients mad, okay? All right. So let's get down to the different diagnoses of a tooth, their symptoms, and the treatment. Okay, so I've tried to order these treatments from least invasive to most invasive. Okay, so it's very important to have an understanding of all of the different diagnoses. Okay, so obviously we have symptomatic gingivitis or periodontitis. We get this all the time. Patients come in, um, usually, let's just pretend that it's a recall patient. Patient comes in, says, "Hey, I've got a toothache on number 30." Okay, and we come in, we ask, "Well, is it waking you up?" Why do we ask if it's waking them up? Because that gives us the differentiation between spontaneous pain and non-spontaneous pain. If it is non-spontaneous pain, um, that we're looking more towards something a little bit more um, uh, easily to be taken care of. If it is spontaneous pain, then it's going to be a little bit more serious, okay? But for non-spontaneous pain, it's very rarely that we're going to need to do a root canal, okay? So, um, um, with gingivitis, it can be lingering pain, often diffuse, meaning it's on a couple of different teeth, and it can be spontaneous, okay? Then we have reversible pulpitis, okay, which is non-lingering hot and cold sensitivity when eating, okay? And what is our treatment? Filling or a crown. What is our treatment for gingivitis or periodontitis? Localized scaling, okay? What about trauma, okay? So what am I talking about with trauma? They bit down on a seed and now the tooth hurts, or they're grinding at night or clenching. Um, that's the type of trauma that I'm talking about, okay? What is the patient going to present with? Diffuse pain, jaw pain, okay? What is the treatment? Splinting, potentially adjusting the occlusion or an occlusal night guard. One of the other treatments here would be soft food diet, okay? So the other diagnosis would be a cracked tooth and it's functional, okay? Meaning it's cracked, but the patient is still able to chew on it and the crack has not extended through the root, okay? So this can present with lingering and even spontaneous pain. What would be the indicated treatment? Potentially only a crown, okay, if the crack is small enough, but you might need to also perform a root canal and a crown, okay? Now we get into the diagnoses that are definitely going to need a root canal, okay? So symptomatic irreversible pulpitis with symptomatic apical periodontitis, or SIP-SAP as we put it in our notes, okay? This would be lingering spontaneous pain. Now, my issue with lingering is what is lingering? Is it 10 seconds? Is it 15 seconds? Is it 1 minute? To me, lingering isn't something that is super easy to quantify, okay? But anything with symptomatic irritable pulpitis needs a root canal. It's something that wakes them up at night, okay? So whenever I say spontaneous pain, to me, it means, does it wake them up at night, okay? uh, they need a root canal. And the patient will basically say, please, doctor, I can't go another night without sleeping. Can you take out that infected nerve? Yes, we'll do the root canal, okay? The other diagnosis that you absolutely need a root canal is necrosis or apical abscess, okay? So if you see an apical abscess on a tooth, okay, that would need a root canal. Now, there's a difference between a virgin tooth that has an abscess, okay, or let's say a tooth that has fillings that has an abscess, and one that has a root canal that has an abscess. If they've already been treated for a root canal and there's a small lesion underneath the tooth, that tooth does not necessarily need to be retreated or an apicoectomy. If it is asymptomatic, what I usually do is I tell the patient that we're going to watch that lesion over a few visits, over a year or two. If that lesion gets smaller, we're good. If the lesion stays the same size, we're good. But if the lesion gets bigger, then we need to address it by usually going down to the root canal specialist and they'll take a look at it, okay? Okay. The final diagnosis is a cracked tooth that's non-functional. What does that mean? A tooth that has been either split all the way down the middle or that has a crack down the root that allows bacteria to continually invade the periodontal ligament area, and it will never be functional again, even if we try to do a root canal, even if we try to do a crown. Okay, so what is the diagnosis with that, or what's the treatment? We're going to do an extraction. Okay, so um, again, you need to understand these diagnoses and try as much as possible to be perfect on your diagnosis so that you can get the right treatment. And you need to be, again, sad if it is one of these more invasive procedures because you would prefer it to be something that you can take care of therapeutically or with just a filling or scaling. Okay. So the following diagnostic protocol should be used for every tooth, okay? So following this protocol will result in less unnecessary root canals and will increase the patient experience and trust with the doctor, okay? A huge concept that I think you've heard a couple of times here is the less dentistry you want to do, the more dentistry you'll end up doing, okay? Why? Because if you're found out to be a doctor who loves to do root canals, no one will want to go to you. And every patient will actually tell their friends not to go to you. But if your reputation becomes that you are a doctor that will do everything possible to not do a root canal, that all of your patients will send all of their friends because they know that you are that guy that doesn't want to do root canals or that gal that doesn't want to do root canals. So become that doctor that does everything to avoid root canals. But when you do have to do root canals, you do an amazing job. Okay. So you have to understand all of the diagnoses, their symptoms, and their treatments. Okay. The only diagnostic tools you will need are patient symptoms, radiographs, percussion, okay, and probing. Okay. The first question to ask when presented with a toothache is if the tooth is waking them up at night. We've already talked about this. That means spontaneous pain. Spontaneous pain, if not solved, will make the patient lose trust in you. You have to get rid of spontaneous pain, okay? Spontaneous pain does not indicate the need for root canals, as it can be presented in localized periodontitis and non-functional cracked tooth. So if you eliminate the diagnosis of periodontitis and non-functional cracked tooth, the tooth most likely has SIP-SAP or a functional crack, both requiring a root canal. The use of endo ice is absolutely contraindicated in a general practice setting. Okay. So if a patient presents in pain, the last thing they want is for you to put frozen object on their painful tooth. This is the way to lose patients fast. So we've already talked about that. Bring your mother in and I'll do a root canal on every single tooth that is non-responsive to endo ice if you really believe in that. Okay. Okay. Um, if after eliminating the diagnosis of periodontitis through localized scaling or Paradex use and possible antibiotic, the diagnosis is most likely a functional cracked tooth or SIP-SAP, and the patient will be asking you to do a root canal on the tooth. Okay. So That's what we want to get to. Patients asking you to do a root canal on the tooth. Because if it ever fails, they were the ones that asked you to do it. You never said, let's do a root canal on this tooth that doesn't hurt. Okay. So here's some scenarios that happen all of the time. Okay. So patient comes in for and they say, and it's basically going to say on the appointment, toothache on number 29. Okay. So doctor comes in, hey, I heard you have a toothache. And the patient's like, yep, I've got a toothache right over here on the right side. So first question, does that tooth wake you up at night? The patient, no, it only hurts when I'm eating or drinking. Okay. So we, again, non-lingering. Okay. So I'm thinking that it's basically, one of these potential diagnoses: gingivitis, pulpitis, or reversible pulpitis, or trauma. Okay. It is not spontaneous. Okay. So what are we going to do? We're going to grab an x-ray. Okay. Because we want to see if it is caries. Okay. So, and um, so what we'll put here is, okay, so by your symptoms, it looks like we might or need a filling or a crown. Is that what you were thinking? AKA, we want the patient to basically, we want to come up with our game plan with the patient, okay? So we order a pano for a new patient or a periapical for an existing patient. If we see that there's caries, we do the filling, okay? Okay. So kind of the same scenario with symptomatic gingivitis or periodontitis, okay? So doctor says, hey, thanks for coming in. I heard you have a toothache. Patient, yes, points to tooth number 29. Does the tooth wake you up at night? Yes, I haven't been able to sleep lately, okay? So now we're thinking either periodontitis or SIPSAP, okay? Okay. So let's grab an x-ray and see what's going on. There are two ways that a tooth can wake you up at night. Either there's bacteria around your tooth and it inflames the gum and especially the ligament that holds your tooth on, and then this can translate into hot and cold sensitivity and especially biting sensitivity. The other way is if bacteria has been trapped microscopically under a cavity filling or a crown and then finally makes its way to infecting your nerve. In the first case, we can simply clean around the outside of the tooth to get it feeling better. The second case requires us to remove the infected nerve. That's called a root canal. Both of us don't want to do a root canal, so let's see if we can get this thing going in the right direction therapeutically. So we order a pano for a new patient or a PA for an existing patient. Then, if we note no apical pathology, the doctor asks the patient to point to the tooth they think is causing the pain. Then what we'll do is we'll tap lightly with the backside of our mirror on teeth around the tooth that they point to, okay? So we'll tap lightly, and at that time we'll say, I'm going to tap on a couple teeth. You tell me which one is the one that hurts. So we'll tap on, let's say, tooth number 31, and we'll say to the patient, is it number 1, number 2, number 3, number 4, okay? And maybe the patient's like, ooh, I think it was number 2 or 3. So then what we're going to do is we're going to go in the opposite direction and see if the patient can tell us which tooth it is, okay? Because if they say, oh, I think it was number 3, and we had started on 31, meaning it was number 29, and then we go in the opposite direction, we start on number 27, and they say it's number 3 again, hey, it's probably tooth number 29 because we've gone in both directions, okay? So if the patient can't identify the tooth, it's most likely the pain is causing multiple teeth to hurt, and you don't want to do a root canal on the wrong tooth. So what I'll say is, let's try to get this tooth going in the right direction therapeutically. I'm going to clean around the tooth, okay? So what I'll do is I'm going to clean around the tooth, and then what we'll do is, it's if it's coming from the outside of the tooth, I'll clean up around the tooth. I'm going to probably get you on a prescription rinse, okay? And I'm going to let you use that for a day or two. Now, if the pain still doesn't go away, then I'm going to give you a prescription for an antibiotic today. And if after 24 to 48 hours we can't get it going in the right direction with the flossing, then I'm going to have you get on an amoxicillin. That way they don't go right on the amoxicillin right away, okay? But if it doesn't go in the right direction very quickly, or if it's getting worse, even on the antibiotics, come back in and we'll have to do plan B, okay? So when you're going around that tooth, you might want to start probing too. Okay, if it starts bleeding, what are we thinking? Our diagnosis is more. In fact, I love it when it starts bleeding. Why? Because then I'm thinking more towards gingivitis or periodontitis, which is like, oh great, we can get this going in the right direction, very non-invasively. Okay, so. Um, so we get one of the most important things too is when you're doing this localized scaling, make sure you go and find um, their next hygiene visit and put a note on there that, hey, I scaled around tooth number 29 on this date with your initials. That way, I mean, I have so many patients that come back and then your hygienist is like, oh, they don't have any more pain on number 29. That was 6 months ago. It's super, super important and for the hygienist to know that. And then the patient is reminded and you are reminded, oh, great. See, we got away without doing a root canal. How awesome is that? Okay. And the patient will gain an enormous amount of trust in the doctor for not wanting to perform the root canal, and they were able to eliminate the pain, and the patient will also want to be more diligent in their routine cleaning visits. This is the best scenario, okay? So you probe around it, then you take out your hand scaler. Why do we have hand scalers in every operatory? So that you can just pull that out real quick and scale aggressively. You're going to floss around the tooth. You might check occlusion to make sure that it's not trauma. You're going to ask the patient if they bit on something, but your best case scenario is it's just localized gingivitis, okay? So let's go on the routine for SIP-SAP, okay? So same thing. Thanks for coming in. I heard you had a toothache. Yes, points to 29. Does it wake you up at night? Yes, I haven't been able to sleep lately, okay? So we grab an x-ray and see what's going on. What are we grabbing? We're grabbing a panel for a new patient. We're grabbing a PA for an existing patient, okay? So we say the exact same scenarios. Two different ways that this could be caused. One, bacteria on the outside of the tooth, or bacteria on the inside of the tooth. Again, do you see that we are saying the exact same thing? In fact, when I came up with this little narrative, I copied and pasted the same thing. Okay, so we noted no apical pathology. Doctor asks to point to the tooth. Then we go and we tap lightly, 1, 2, 3, 4, go in the different direction, 1, 2, 3, 4. So what we're going to try to do, we're going to try to get in the right, going in the right direction therapeutically. We do the exact same thing. Give the amoxicillin, Paradex rinse. Okay. The patient presents to the clinic 2 days later with unresolved pain on number 29. At this point, the patient already knows what's going to happen. The patient wants the root canal because they've already gone through this scenario. They've been at home flossing like crazy. They've been on the Paradex rinse. They've been on the antibiotics, and it won't resolve. So they know that they need a root canal, and they're going to literally ask you to do a root canal on that tooth because they haven't been able to sleep in the last couple of days. So before the antibiotics, the patient had a 10 of 10 pain on 29 and an 8 out of 10 pain on 28. But after the antibiotics, the patient has a 4 out of 10 pain on 29 and a 2 out of 10 pain on 28. So now they're able to identify exactly which tooth it is, and they can easily point to tooth number 29 as the source cause of the pain. Doctor gladly gets the patient out of pain by performing the root canal. Okay. So do you see how easy that is? And it happens all of the time. And the patient is happy that you're doing the root canal. And the patient trusts that you know what you're doing, that you don't want to do root canals. And if the root canal fails in 5, 10 years, guess what? The patient knows that it was their fault that they didn't clean up around the tooth, and they were the cause of needing the root canal. Okay, not you going and do a root canal because you wanted to do one. Okay, necrosis or apical abscess. Okay, so patient comes in with pain on tooth number 29. Um, does it wake you up at night? Yes. We grab an x-ray to see what's going on, okay? Then what happens? Instead of not seeing apical pathology, yes, we do see apical pathology, okay? We bring the patient to see the x-ray with the apical radiolucency. So this is a nerve that was infected and now it died. Bacteria is under your tooth causing this abscess. We need to eliminate the ability of bacteria going down your nerve and under your tooth into your jaw. Okay, this is called a root canal. Are we going to try to get it going in the right direction therapeutically? It's just not going to work. We already know that we need a root canal. The patient has already come in with pain. Okay, so if a patient really, really wants to, they're like, I do not want to do a root canal. Fine, I will definitely get them on antibiotic and see if it resolves. 10 times out of 10, they're going to come back and it's going to be an issue. Okay, maybe 1 out of 1,000 times, maybe you misdiagnosed it and it's actually the mental foramen. And again, you're glad that you didn't have to do the root canal, but most of the time, I would say 99.999%. You and the patient are going to be glad that you did that root canal because it was causing them an abscess in their head. Okay, so again, this endodontic um, protocol is super important in order to get the correct diagnosis, treat every patient like you would your own mother, and um, essentially ensure that there's no problems in the future. When or if your root canal fails, um, you will have had an absolute diagnosis because the patient wanted that tooth to be root canaled.